This is Guillaume Martel. I'm a surgeon, HPV surgeon here at the University of Ottawa, and my co-moderator is Dr. Jonathan Cham from the University of Washington. Welcome. This is the AHPBA webinar on clinical trials, and we're doing a session today specifically on patient-reported outcomes in clinical trials, design and utilization. So thank you for attending. For those of you who are here, this is a QR code if you're interested in filling a survey to help us out with one of our clinical trials committee pet projects, so to speak. And so feel free to join. I'm going to introduce our first speaker. Let me stop sharing so I can read my notes at the same time. Our first speaker is Dr. Naru. Excuse me, let me just put my notes up. So Naru Ikoma, who is a assistant professor of surgery at MD Anderson in Texas. He is a surgical oncologist who specializes in MIS and robotic surgery with an interest in pancreatic cancer, biliary tract cancer, and gastric cancer. He's completed fellowship at MD Anderson as well as Keio University in Tokyo. He's board certified in both the US and Japan, and he has a master's degree in public health from the University of Texas School of Public Health. His research interests include improving short and long-term treatment outcomes using MIS and surgical techniques for pancreas and gastric cancers. And he is an expert in patient-reported outcomes in clinical trials. So welcome, and we're really grateful to have you.
Thank you very much. Can you hear me okay?
Yeah.
Okay, so thank you very much for this opportunity. I'm very excited to talk about this very important topic, in my opinion. Just want to clarify that I don't consider myself experts in this field, but I'm learning and I've done some work, and I'm happy to share my what I learned so far, and I'm looking forward to learn more with following talks too. So COI, I received the Intuitive Surgical Research Grant a couple of years ago, indeed, to develop the new patient-reported outcome tool. But I don't think the talk we're going to give is not going to be affected by any industry influence. So I'm going to start talking about why I think it's important to study about the quality of life in surgical oncology and HPV surgery, and quickly describe what are the PROs and PRO measures being commonly used. And then I will share my experience of the development of the new patient-reported outcome tool, which is named MDASI upper GI surgery. So a little bit background on myself. Introduced, my specialty is pancreas and gastric cancer with the use of the robotic technology. I'm a 6th year as a faculty here, and I'm being spearheading the surgical oncology, robotic surgical oncology program here with a focus on those organs. And I say probably 90% of the cases I do is being done by robotic surgery approach. But I've been asking myself why I'm doing the robotic surgery for cancer patients, because length of incision is the last thing I care about. And then the recovery is more importantly how we do inside of the organs. And then we are taking longer time by using the robotic approach. So I feel like we need to justify that. And these are the patients after surgery, indeed after open pancreatectomy. This lady on the left side, the DP cuff 5 years ago, she just rang the bell for the NED. And her recovery was excellent, and then doing great, and she absolutely doesn't care about her incision on the belly. This gentleman on the right side also had the Whipple procedure with open approach with a vein resection, and she texted me like maybe 2 months after the surgery, showing off his incision, nicely covered by hair, and he absolutely doesn't care about the incision, and he was satisfied with the recovery too. So my mission is to define what is the value of the robotic surgery in patients with who are undergoing once in a lifetime operation for the diagnosis of cancer for the pancreas and gastric cancer. And then my research projects is all around this topic, and then quality of life is definitely one of the most important topic I've been working on. So we sent this value survey to the patients who had undergone pancreatectomy or gastrectomy for the recent years at our cancer institution for the diagnosis of cancer. We asked them to rate the importance of these metrics or these aspects of the surgery they had. Obviously, the survival, removal of the all cancer cells are being rated consistently very important all among the patient with different age group. And that is pretty much why they're undergoing the surgery. They're naturally understood. And we noted that the length of hospital stay and length of incision are not important for them, even though these metrics are being considered as the main benefit of MIS approach for any kinds. So these are not pretty patient-centered outcomes if we are doing a study. Instead, what we would be able to improve the outcomes by using the MIS approach would be avoiding the complication and helping the patient to return to normal life or return to normal quality of life after surgery. That's why in our study, particularly investigating the benefit of the MIS, should focus on this metric rather than length of incision. Quality of life is defined as a broad range of human experiences related to one's overall well-being. It implies value based on subjective functioning in comparison with personal expectations and is defined by subjective experiences, states, and perceptions. So all other conventional outcomes always value objectivity, but PRO is important and meaningful because it is totally subjective outcomes. And so that's why we have to ask patients to report their symptoms and quality of life and defining the patient-reported outcomes. PROs provide reports from patients about their own health, quality of life, functional status associated with the healthcare and treatment they have received. And when we are having such a shift, a recent shift towards patient-centered, value-based healthcare, cancer care, quality of life and patient-reported outcomes will continue to play an important role in the near future. However, we know the challenges exist in PRO studies, particularly for the surgery because of these biases as listed. To overcome those biases, patient-reported outcomes should be collected prospectively. Otherwise, it is subject to recall bias. Patients do not remember well what they are feeling before the surgery, for example. And if we do send out the survey at the same time point for all patients, there's a timing bias. The timing after surgery or treatment is so variable, and then the outcomes may not be as meaningful as it should be. It is very important to have a high rates of response. Otherwise, it is subject to the non-response or selection bias. And it is generally recommended at least 60%, ideally for above 80%. But even with the 80%, if 20% of the patient may have some reason not to respond, maybe having the tremendous, severe symptoms, that's what, if that is why they're not responding, the missing the 20% skew the data tremendously. And there's a collection bias. To avoid that, it needs to be self-reporting. If the physician is rating patients' symptoms, then we know that patients report their symptoms much higher rates than providers. That is called collection bias. Family can help the patient. That is called the proxy bias. But we know that that is much better. They do much better than physicians. And prompts need to be easily understood and quick to complete. Otherwise, patients started having the fatigue when completing the lengthy patient-reported outcomes, and there's affecting the inaccuracy. And also, it's important to have a baseline measurement. And because the patient-reported outcomes is affected tremendously by personality, I often see the patient is doing great, apparently doing great, eating good. When we talk, patient is doing well, but still they report, significant symptoms when we ask them to fill up. So probably we need some adjustment based on the baseline that may represent the personality traits. Okay, and there are the many different PRO measures being used in cancer research and validated. And then I will quickly go over the measures. And one most commonly being used is a EORTC QLQ-C30, and developed in Europe. It has a 30 question general questions developed for the cancer patients. And they can also add the disease specific additional question. For example, for the stomach, there's a 22 questions. And for the pancreas, there's a 26 question can be added to those C30 to be complementary. And Euro QOL 5D is also commonly used. It only has 5 questions, so often used in conjunction with other questionnaires such as EORTC. And just of note, EQ5D is being used for calculating quality and cost utility analysis. We will touch a little bit about that later. And other commonly used or known questionnaires include fact general, short form survey, and promise. These are being commonly known, being used, but the less frequently than EORTC. That's why I'm not going to talk much about these. And then allow me to introduce MDASI, MD Anderson Symptom Inventory later. So we looked up randomized control trials in the topic of MIS, pancreatectomy and gastrectomy to see how often PROs are being incorporated in those studies. And although PROs are likely the main benefits of MIS, those studies incorporating PROs were surprisingly rare. We were able to list all of them as much as we could tell. And most studies were from recent years from Europe. And then all studies in gastric and pancreas studies, EORTC questionnaires are being used for those studies. Let me pick Leopard study, which is from Netherlands. They compared MIS versus open distal pancreatectomy, enrolled 108 patients. Primary outcome was a function of recovery and their definition. For the secondary outcomes, they collected ERTC, QLQ-C30, and EQ5D questionnaires at these timing. Like I said, EQ5D is very easy to repeat. That's why they added day 1, 3, 5. But EORTC was only asked to complete 2 weeks, 1 month, and 3 months. They reported outcomes being improved by MIS approach for those QOL metrics. Let me quickly go over what those questions entails. So EQ5D questionnaire only have 5 questions: mobility, self-care, usual activity, pain, discomfort, and anxiety, depression. And they use the 3-point Likert-like scale in 3L form. They also have a 5L forms, which has a 5-point scale. They use today recall period. Recall periods asking the patients to report about the symptom for when, and then EQ5D used today. So it may have some different the implementation or implication if we ask this question in the morning or night. And like I said, this is often used to calculate quality or the cost utility analysis by using the conversion score from these 5 questions into one single number ranging from 0 to 1, 1 meaning the full health, and to evaluate the quality and then calculate the analysis. They can also ask one additional question, ask the patient to rate their overall health status in the range of 0 to 100. Then ERTC, in comparison, they have a different the recall period, and then they ask the patient's experience about the past week. So it has a 7-day recall period. And instead of 3, they have a 4-point, like a Likert-like scale. And so there's a little bit different. Like I said, it is very well structured. Language is very easy to understand. And I totally understand why this is being most commonly used as compared to others. But for today, let me try to be as critical as possible. And then let me review what the problem would be for of this questionnaire. Let me start with the first 5 questions. They ask about activities. And do you have any trouble doing strenuous activities? Followed by long walk, short walk, bed during the day, and then do you need help for other daily activities? In my opinion, there's a significant overlap in the answer. If the patient having the difficulty walking the short walk, for sure they're going to have the problem in the long walk as well. If the patient is in the bed for the whole day, they're probably not walking. So it's maybe important for some studies, but I didn't feel like we need to spend 5 questions to ask about these activity questions. And followed by these 2 questions, asking another question about activity, and one for the work, one for the hobby. Again, I expect significant overlap or similarity in the scores they would report. If I cherry pick this, did you need to rest? That's tricky question. All of us need to take some rest, and particularly after working or like running. So it's hard to interpret what their answer means. And this is the second page for the C30. And let me pick this. Were you tired for the past week? Of course, I was tired after a long case last week, but it does not necessarily mean my quality of life is interfered. And there's the section of asking about the emotion. How do you feel tense? Did you feel tense, worry, irritable, depressed? Again, I felt maybe redundant to ask a similar question again and again, and then not worth asking repeatedly. And then if you want to have more specific question about disease specific site, this is example for the stomach 22 questions. And start with those. Do you have a problem? Solid food, liquid, soft food, drinking liquids, discomfort when eating, followed by pain, stomach area, discomfort in stomach area. So, to say the least, these are similar to each other to some degree. And again, the overall, if I have to ask like a 52 question, probably if I were the patient, I guess I started feeling fatigue, and the latter, the answers may be inaccurate for the time being. And then after having those ERTC completed, there's a user guides how to analyze them. They can be added all together, or you can pick some of the question to have a composite scores, like a global health status, functional scales, symptom scales. Those kind of things can be combine them and to be reported as a part of the outcomes. So this is the example, the Leopard trial, like I explained earlier. The first, this is a section of the quality of life measurement results of the study. And then on the left side on the figure, they reported EQ5D state of health visual analog scale. This is, like I said, they report the overall health status in the scale from 0 to 100. They found that the MIS approach would help the patient's symptom from day 1 to day 30, but the difference was not present at the day 90. And the next outcomes they showed was QLQC30 global health status, similar outcome. They showed some difference day 14 and 30, but probably not different on 19. But what is global health status? Let's go back to this table. They used 2 items to make this composite outcome for the global health status. So of course, they reported all outcomes in the supplemental table, but after asking 30 questions, they only used 2 to make this figure. So I felt, the most of the questions were not being utilized effectively to contribute to this study. So let me talk about how to choose the prompt for your study. And then the one thing I learned is that you cannot create for yourself for the random fashion. You have to use the prompt to be designed and validated. And then I'm going to talk about that, but it's a lot of work to validate the prompts. But you cannot create the random one to be used for your convenience. And so next step is going to be to know previous studies in the field, like I showed you. And important to know question items to make sure you get the answer what you want to know. And pay attention to the survey fatigue. And like I said, if I ask patients to complete ERTC C30 and pancreas 26 question, you're going to end up asking them more than 50 question, and then some overlapping question, possibly confusing with 7-day recall period. So I didn't quite find the great the questionnaire for my study, and so we decided to make a new one. And fortunately, we do have the symptom research department, and I was fortunate to have a collaborator to help me to do that. So let me introduce the MD Anderson symptom inventory. We call that MDASI. And we like this format because the language is very easy to understand. And like you said, we ask the patient to report their symptom severity from 0 to 10. 0 is great, 10 is very bad. You can see each line, pain at its worst, fatigue. So you don't even need to read the whole sentence. It's just the word. And it's once you get used to it, you can get this whole survey done less than 3 minutes. And MDATI used the 24-hour recall and asked the patient to report at its worst. And at least it is very clear when you're supposed to report and then what the time you're going to report. The survey being shown here is MDASI GI, developed for the gastrointestinal cancer patients. But the problem is this, included many variety of GI cancer patients, but a majority of the patient contributed to development was the colorectal cancer with the stage 4 disease. So the part I didn't like was the question is about stoma, and it didn't have upper GI symptom like a reflux or any symptom associated with the dumping syndrome. And then we do have other MDASI esophagus that is developed for the radiation patient. And we do have MDASI liver, Dr. Aloya made one. We have MD Anderson GI obstruction, Dr. Bajo made one. But we still lacking specific one for the upper GI, namely gastric and pancreas patients. So we decided to make one. So I'm not going to go too detailed about this, but Sam Cass as a T32 fellow with us last year, and Paula Smith, she's the surgical oncology fellow, has been doing a phenomenal job to do this. And then the development of the new prompts have multiple steps. It starts with qualitative interviews. So we enrolled 20 patients with upper GI cancer, namely esophagus, stomach, and pancreas cancer patient who underwent cancer operation. And we spent an hour for each one, and we asked them to share their experience about the symptoms. And then we listed those symptoms and send those lists to expert rating. We had 6 surgeons, 6 patients, and 6 caregivers to rate those each symptom item and then to make sure those lines are relevant, they think relevant to those patients, worth asking. And then now we finalize this process and then moving towards a psychometric validation. We have to, we're going to enroll a 150 patients who undergoing the esophagectomy, pancreatectomy, and gastrectomy, and to do the psychometric validation. And this is the question we included in the MDASI GI surgery preliminary list. And one questions in the red box is the one specific for disease site, and others are called MDASI core questions, and we kept it in. So I hope we can finish those validation study within 1 year. But once it is finalized, we hope that we can use that to quantify quality of life in dynamic fashion, because we can repeat that multiple times very frequently. And then to enable describing the difference in the cumulative quality of life by showing the like an area under the curve, and then to enable intervention to improve patients' quality of life at each specs time point throughout the care of the cancer treatment, including neoadjuvant surgery and adjuvant therapy. And this is one study I want to introduce lastly, is that we are working on this multi-center collaborative study, 3 centers from the US, 2 centers from the Asia. Proximal gastric is one of the big topic in the gastric cancer field, but we don't know whether that is helping the patient's quality of life in comparison to total gastrectomy. So the unique thing about this study was we decided to have the quality of life as a primary outcome, and specifically for the appetite level at the 3 months after the surgery. For this study, the upper GI surgery is not still ready, so we are using the MDASI GI plus. You know, the MDASI GI is still lacking the reflux symptoms, so we added 3 additional questions on that for the use for this study. We are enrolling very nicely. We aiming the 60 patient, and then so far it's about 55 patients. So I hope we can report the results very soon. Sorry, I was a little bit over time, and thank you very much for your attention. And I truly thank my collaborators, mentors, and colleagues and postdocs and APPs helping me to collect those the patient-reported outcomes, and we have been achieving the great response rate so far. Thank you very much for this opportunity.
Thank you so much. That was very interesting and insightful. I think we will have questions at the end, so people write them down, and we will have an opportunity to go over them. I'll turn the podium over to Dr. Shan.
Thanks so much, Guillaume. I have the honor to introduce our next speaker, Dr. Robert Kraus, who is a professor of surgery at the University of Pennsylvania and the chief of surgical services at the Corporal Michael J. Krentz's Veteran Affairs Medical Center in Philadelphia. He is a world expert in cancer survivorship and palliative end-of-life care. He is co-chair of the SWOG Palliative End-of-Life Care Committee and has been principal investigator for multiple multi-center trials, evaluating issues across the palliative care spectrum, including quality of life in cancer patients with stomas, rectal cancer function outcomes, and he was also principal investigator for SWOG 1316, which evaluated quality of life outcomes in patients with malignant bowel obstruction. On a personal note, he's just an outstanding mentor and stand-up guy who has guided me through the cooperative group process over the last few years. And he'll be speaking today on how to incorporate PROs into your clinical trials.
Okay, thank you. Can you hear me and you can see my slides? Great. So Dr. Ikoma, really it's helped me out a lot with my for my presentation. There'll be a little bit of repetition, but not too much. I'm going to really focus on some of the basics that he reviewed, and then how to actually use them. And I'll use quite a few examples. And so my disclosures are going to be these different funded studies through different grants, PCORI, NIH, and HRQ, and to give you different examples and ways to use PROs in your trials. So when do you use PROs in trials? Well, first of all, you can use it as a primary outcome or a secondary outcome. Primary outcomes are more and more funders are more and more open to using a PRO, or as stated, a subjective outcome measure as a primary outcome. And I'll give some examples of that. PROs are often also added as a secondary outcome, as a really important secondary outcome in survivorship trials or other behavioral trials. And more we see, especially in SWOG and other of the large cancer networks, that often to survivor trials, maybe there's someone comes up with an idea of an important quality of life endpoint that you want to measure, so they're added on. So a good friend of mine, Jeff Sloan, was unfortunately passed away recently, but he was at Mayo Clinic. He was a statistician, very well known in the world of quality of life, what are meaningful differences, etc. And one thing, as said, is PROs need to have the same rigor and usability as lab tests. You think of it as a test, as something you want to get an important outcome. In fact, I have when we look at these things, I consider them lab meetings when we review our data and certainly on top of our trials. They need to be accessible, easily, either through the computer or, as you saw some of the MDOSI and others, easy to fill out. Interpretable. Are they meaningful? Do they make sense to the audience? And they must not be burdensome. That was mentioned, but it's really an important. Whenever you're considering your trial, you have to make sure that it's not going to be a massive burden to the patients. They're going to finish the survey. And then, of course, measuring general or individual facets of quality of life. And so there's quantitative, and so a lot of these were reviewed by Dr. Ikoma. You can think of and that's why general quality of life sometimes are added with symptom-specific quality of life measures. You can use different ones, disease-specific, City of Hope, FACT, and MD Anderson, et cetera, have different versions based on what they want to focus on. There's functional surveys, and LARS and MSK Bowel Function Index. I'm going to talk a little bit about those, and others that really you can utilize to get the targeted endpoint that you really want. Now, I'm just going to very briefly mention qualitative, because qualitative really are patient-reported outcomes. In fact, that's how using qualitative outcome interviews and focus group is one major way that these different surveys are created. What's important to patients? In a lot of the surveys that we use, especially from City of Hope, there's an open-ended question often in the survey, asking about a specific issue. Do you do this, or what is your biggest problem, etc. And that can actually be really used in an exploratory fashion, or really to help explain what you're looking at. Okay, so another big thing when you're designing a trial is, when do you do the surveys? Obviously baseline is really important. Do you do it during an intervention? Well, surgery is the intervention. Other chemotherapy trials and all that, of course, are more ongoing. Do you do it at the completion of the intervention? During follow-ups, what are the points of interest, et cetera? These are all the things that need to be considered. And of course, the big issue is not being too burdensome, not giving people surveys too frequently so that they really won't fill them out. So considerations, burden is really important. If you don't get the data, then you're not going to really get the information you want. So will they complete the survey? And then how are you going to use the survey, the background data, survey data, to power your study, if it in fact is your primary outcome? What's reasonable for missing data? This is where you need really truly statistical expertise, because when you start getting in a survey and if more than 50% of the data is missing, is that really usable? And if it is, you do have missing data, do you go back and get it? Do you re-quiz the patient, or you say this is not really viable? And then for those who haven't used surveys too much, there's the question of imputation. Say you have a survey that is almost completed. Can you impute what would this patient probably, the status, their statistical programs, what they probably have done? And there's certain instances when that may be a reasonable thing to do. Okay, so my first example is going to be S1316, which Dr. Sham mentioned, a prospective comparative effectiveness trial for malignant bowel obstruction. We completed the study within SWOG, and a brief schema. This was a sort of a mixed design study. We had a randomized component and a non-randomized component, and all patients had to be randomizable. They all had to be surgically eligible with a malignant bowel obstruction and equipoise. Surgeon or surgical team wasn't really sure whether it'd be better or worse. This to get an operation or a non-operation. This took around 5 years to accrue. We were able to complete accrual, which of course, as you can imagine, this population was a pretty big deal. And over multiple sites, MD Anderson was one of them. Dr. Badgewell was the site PI. You saw his picture multiple times on Dr. Acoma's slides. So our primary outcome for that study was good days. It was a composite, days out of the hospital alive within 3 months. Pretty important outcome for patients. And this was based on sort of lots of background data in patients facing the end of life. Secondary outcomes are surrogate quality of life measures, Bayes, NG, we measure morbidity, days eating. Now that is a patient-reported outcome, certainly, and there was very little data in the literature, and so I'll show you how we sort of acquire that data, and that was based on diet recalls. And then we did use 2 instruments. We used MD Anderson Symptom Inventory, GI. Dr. Badgewell hadn't created the obstruction version yet, and that, there's a general MD Anderson Symptom Inventory. The GI has really important, very specific questions that are, of course, related to people who may have an obstruction. And the EQ5D was well reviewed, but we wanted to include that also. It's really quick and easy, and also it can give information like qualities. Now, this is how the timing of how we did things. So first of all, once they were accrued to the study, they did the surveys, and then we got the survey information every week until week 13, and then you can see we got it monthly after that until the end of a year or death. Obviously, about half the patients died by week 13, and the dietary recalls were done monthly. I will say that we basically we published the findings, and I don't, this is not a data-driven presentation, but really a sort of thinking about how to use PROs. But we found, just so the punchline, which we published in Lancet Gastroenterology and Hepatology over the summer, was that there really was no difference between surgery and non-surgery in good days. But there was a difference, or there was benefit to surgery, early surgery, related to symptoms, malignant bowel obstruction symptom-specific questions about bloating, pain, nausea, vomiting. It's interesting, and so basically, just as an aside, the MD Anderson Symptom Inventory, you see that there's sort of 2 domains: symptoms and how it affects you. But you can also use that survey for individual questions, which you cannot do for every survey, which I'll talk a little bit about. You can't, a lot of surveys are set up just to look at the domains, the combined questions, rather than the individual questions. Okay, so another study I want to talk a little bit about is a telehealth program for ostomy, self-care for cancer survivors. I'm going to be talking about a PCORI-funded study. But the first slide I'm going to show this was an R21 that we did when I was at the University of Arizona. And basically, we designed a curriculum based on a lot of background work. looking at, and the curriculum was in multiple sessions to really impart knowledge and experience with different quality of life related items, healthy living, social, psychological, work related, and sort of basic care issues that some patients really either never learn or forget or whatever. So we had these were in-person sessions, and these were ultimately the findings. And you can see the timing was we did pre-sessions, post-sessions, and then we did 6-month follow-up. And then we had multiple surveys. We had patient activation, self-efficacy. We had total quality of life using a City of Hope instrument, which has 4 domains: physical, psychological, social, spiritual. We used the HADS, Hospital Anxiety and Depression Scale. And then we also have satisfaction. And as you can see, in the sort of the purplish color, we really found a statistically significant difference over time for most of these things. Now, of course, the question was it just time, or was it the intervention we created? And that's what led to the PCORI study. But I just wanted, so patient activation and self-efficacy, what are those and how important are those? Those are surveys. Patient activation is taking action to maintain and improve one's health, staying on course, even when under stress, and not giving up in the face of challenges. It's really only 11-question survey. And then the self-efficacy is confidence to carry out behavior necessary to reach a desired goal. That's actually in different blocks of questions. How confident are you with this or that? And actually, one of the investigators in our study was the person who designed the patient activation survey. And also one of the person on our study was the one who designed the City of Hope survey, which I think for all of us, we're surgeons. What do we know? And so having people on your team that really can help mentor through the analysis, especially the analysis, is really critically important. So basically, this study was, this is when we used patient activation was our primary outcome measure. So it was we had lots of secondary quality of life measures, self-efficacy, knowledge, related quality of life, etc. And then we used telehealth. This was pre-COVID, luckily. And so we designed it to be telehealth, sort of like we're doing right now, which at the time was pretty novel. Usual care versus this intervention. And then we also had a healthcare utilization survey that we created. Now, Dr. Ikoma is exactly right. You don't want to willy-nilly create a survey, and going through the process where you validate and ensure reliability is really important. Getting healthcare utilization or financial burden is really hard. It's a very expensive process. So we created a survey. There was a very well-known health economist who created it based on other questions used from other instruments. And so this is the basic schema. And so you can see we had baseline surveys, and then the interventions, we had surveys after completion, and then 6 months, sort of, in a similar fashion that as the pilot, only we had our comparative group. And this is my one data table anyway. And this was a negative trial, essentially. If you don't have to go through all these, it was not a positive trial. It was published in Cancer because it was rigorously done. And the primary outcomes, all of the major outcomes were PROs. So over time, now there are likely a lot of reasons, and I'll sort of go over a little bit why we feel we didn't get a statistical benefit. Although there are some indications, at least for the urostomies, this is a forest plots. The one on the left is baseline versus post-intervention, and the one on the right is baseline versus 6 months. You can see there certainly looks like there's trends in the right direction of benefit, but it wasn't statistically significant. Now, our next study that we are actually currently finishing right now is a continuation of that study, only focusing on rural population. Rural populations, as you may know, are deemed a disparity population. And as you can also imagine, telehealth, which in some areas may be difficult, it also could be very helpful, because coming in to see the major resource, ostomy nurses, and we also have peer ostomies, people who've had ostomies who also help in these sessions. Really difficult for people living sort of farther away. So this is the schema for this study. It's essentially the same, but a little bit different. And so you get baseline surveys, and then we have surveys when it's completed, and then we added 3-month surveys, and then we have 6-month and a year. We added longer as well. So were we missing some of the time points that really were important that maybe we would have seen a difference? Now, over time, most people will adapt. And so that maybe fights against, sort of a really big statistical difference. And that may be why it was good to add a 3 months time frame. We also added some questions that we found were really beneficial from the original study, from the pilot, related to satisfaction related. We actually added also, which I didn't include here, a couple diet related questions that may be of more import, especially for rural populations. And so we didn't add the satisfaction survey in this. You just to limit burden. You can not only the patients may not fill out the survey. We also know the reviewers will that's going to be a comment you see when your grant is reviewed. And ultimately, our original sample size had to increase because of that, because of adding a new time point. And so this is just an FYI. You won't see this published for probably another year, because we're just finishing accrual right now. You can see with the major centers where we ended up for those, and I'm happy to answer questions down the line for anybody who as far as getting a study done. But accrual is everything, and sometimes you have to add sites that you weren't anticipating, and figure out how to make that happen. So the last example that I want to go over is a study that finished recently. It's another SWOG study, randomized trial of altering intake, managing symptoms, intervention for bowel dysfunction in rectal cancer survivors compared to healthy living education controls. So this was sort of phase 2 feasibility study. So a curriculum was developed from University of Arizona, Dr. Thompson, Dr. Crane. Dr. Sun was the one who ultimately was the PI of this R21 grant in the study through SWOG. She's at City of Hope, a nursing researcher. I've worked with her for quite a while now, and she joined our team and used a lot of the data that we had, basically some of the text data, the qualitative data. She analyzed that and thus found some of the interventions that these patients were sort of craving, and designed this study. So basically at baseline, she used surveys, which I will review with you. To be part of the study, the patients had to have a bad enough bowel function, because the primary outcome was bowel function, which is really novel. And that's one of the things that the reviewers really, really liked. So using a LARS, that was sort of if patients essentially had poor enough bowel function, they were included. And then we actually, and there could be quibbles about this, we used ostomy patients, knowing that they had a poor bowel function. We had used the MD Anderson, or the MSK bowel function index in ostomy patients before, and we had done the psychometrics as relayed, so we knew it worked for that population too. Okay, so just to briefly, so they did surveys at baseline, surveys at week 18, and surveys at week 26. And in the way right, you can see these are all the sort of PROs that were used. But the most important is bowel function index, MSK-TC. Now, Dr. Temple, who was on our previous studies, she was the clinical lead designing this survey, MSK-BFI. And you can see there the other surveys that were ultimately used for this. And so just briefly, the primary aim was using a bowel function PRO at baseline to 18 weeks. And then basically, then some of the secondary outcomes were then to use some of the individual domains of that survey, and then to look at some of the other surveys, obviously, and then also look at some of the demographic variables. So basically that's, as I said, that the paper hasn't come out yet. It was just accepted for publication, so I can't really say too much more than that. But it was a sort of a novel study. But you can see that you can design a study with a PRO and ultimately get funded and have success. So brief conclusion. You can use a PRO as a primary second outcome. It depending on what you're looking at. Sometimes it's your funder, etc. Multiple factors must be taken into account when choosing the PRO, but I can't stress enough that trial design, including PRO, should include expertise. I know what I know, I know what I don't know, and I know what I know a bit. And so who can help me to ensure that I am designing using the exact right tool, and then ultimately the exact right analysis, timing, etc., to make it a successful trial. So that is it.
Thank you so much, Dr. Kraus. Really impressive work and what's been an entire career in this field. And I'm sure people have a lot of great questions for you, given your extensive experience in this area. We're going to move on to our next speaker, Melinda Bikini. Melinda's a mother of 6 and grandmother to 1 and a 12-year survivor of cholangiocarcinoma. Her passion is patient advocacy, and her personal experience with cancer therapy gives her insight into patient participation in clinical trials. She serves as patient advocate for the NCI Hepatobiliary Task Force, the NCI Patient Advocate Steering Committee, the ECOG-ACRIN GI Committee, ECOG-ACRIN Cancer Research Advocacy Committee, and several others. And she will be speaking today about incorporating patient perspectives into clinical trials.
Thank you, Jonathan. Good afternoon or good evening, and thank you for the invitation to present on incorporating patient perspectives into your clinical trials. Again, I'm Melinda Bikini. I'm the Chief Patient Officer with the Cholangiocarcinoma Foundation. I'm also a 14-year survivor of stage 4 intrahepatic cholangiocarcinoma. I've experienced surgery, recurrence, chemotherapy, stopping all treatments for a better quality of life, and a clinical trial. 3 months after my liver resection, I had a recurrence of disease, and I was given only 6 months to a year to live. Thankfully, a few weeks after stopping all treatments, I stumbled upon a clinical trial with Dr. Steven Rosenberg at the National Cancer Institute. I was the 9th person to enter the trial and the first person to have a response. This treatment is the reason I'm here 14 years later, and I'm incredibly blessed and grateful to be here. And more than anything, I want these results for all cholangiocarcinoma patients. Because I've had such a great response, I wanted to find a way to pay it forward and help other cholangiocarcinoma patients. Because the Cholangiocarcinoma Foundation was such a vital part of my diagnosis, I began volunteering with the foundation 12 years ago. And 7 years ago, I was fortunate enough to be able to come on as a full-time employee. I do my best to bring the patient voice to all areas of research and try to represent all cholangiocarcinoma patients and their patient experience. The CCF mission is to find a cure and improve the quality of life for cholangiocarcinoma patients. We have 2 pillars for our strategic priorities, which includes patients and caregivers and research and breakthroughs. CCF wants to be the center connector of all things that are important aspects for cholangiocarcinoma, and this includes incorporating the patient voice into clinical trials and research. Patients and caregivers are at the heart of everything we do. It is literally my job and responsibility and desire to bring the patient caregiver voice and perspective into research and clinical trials and prioritize the needs of the patients. One way we do this at the Cholangiocarcinoma Foundation is through our Research Advocacy Committee. The research advocates are made up of patients and caregivers who are focused on understanding and learning more about the research opportunities available in cholangiocarcinoma. They attend conferences and webinars and report back their findings to the community. They bring the patient voice to educational programs through ASCO, AACR, FDA, and others, and they serve as consumer reviewers for the Department of Defense Cancer Research Program by reviewing and scoring applications and sharing what the impact of that research would mean for the patient community. They also review grants for CCF, SPORE committees, and the ASCO Young Investigators. Again, these volunteers are lending their personal experiences, learned experiences, and the experience of the entire patient community in research areas, such as reviewing informed consents, protocol designs, patient-friendly summaries, and patient-facing materials. We have found by utilizing the patient voice, there's been success in accrual of trials, understanding of the treatments and side effects, and advancement of research. As a chief patient officer and as a survivor, I make it a priority to provide representation of the patient experience in as many areas as possible. This slide shows some of the many ways that the cholangiocarcinoma voice is being heard by having a patient or caregiver representative on these committees. We provide educational webinars twice a month for investigators and industry to share about their clinical trials. This is a live webinar that is also recorded live on Facebook. We usually have about 50 to 100 patients and caregivers join live, and then the recording is viewed hundreds of times in the next few weeks. This is an opportunity for investigators to describe the clinical trial, the science behind it, and go over inclusion/exclusion criteria. There's not been one of these webinars where at the end of the presentation, the investigator doing the webinar is not blown away by the patient caregiver questions and interactions and their overall knowledge of this disease. Back when I was still a volunteer for the Cholangiocarcinoma Foundation, I sat on my very first industry forum and witnessed the importance of involving patient perspectives into clinical trial design. At the time, Agios came to get feedback on their trial design of having a placebo in one arm. I remember vividly sitting with another patient advocate who had lost her husband to cholangiocarcinoma and letting them know there was no way we could support that design without a crossover option. Thankfully, they added the crossover and accrual was very fast, and ultimately it led to an FDA approval. Recently, we helped author a paper on the importance of crossover in a clinical trial design. I saw the power of the first patient advisory board we held with Insight. I will never forget how fast they were taking notes and really wanting to hear from the patients about their needs, the roadblocks and struggles of facing a cholangiocarcinoma diagnosis. But more importantly, they took that feedback and incorporated it into their trials, patient materials, and resources moving forward. Over the years, we have brought the patient perspective to all the FDA approvals for cholangiocarcinoma. Just today, we held another patient advisory board of an industry partner where 7 patients were able to bring their voice to the table and discuss and share their perspectives, which gave this partner a lot to think about in regards to their trial. Thanks to Flavio and Shishir for the amazing support they provided, we learned a lot about the patient perspective through a survey we did for cholangiocarcinoma and pancreatic cancer patients. The aim was to better characterize patients' beliefs, wishes, and perspectives in cancer care for pancreatic cancer and cholangiocarcinoma. We learned important things like, while half of the patients would undergo surgery if it improved survival chances for greater than 2 years, about 20% would also undergo surgery for survival of only 3 to 12 months. The patients would undergo treatment with severe side effects if it would extend their lives. And we found out that most would endure these severe side effects for 3 to 12 months, but about 25% would be willing to endure for over 2 years. We learned that over 80% are willing to participate in clinical trials. We just needed the opportunity to enroll and to have access. And that 60% of patients would enter into a phase 1 trial, but these are usually given as last-ditch options for patients. And like I discussed earlier with the Agios trial, when it comes to placebos in the clinical trial setting, most patients would only enter into a trial with a placebo if there was an option to cross over after 6 weeks. Otherwise, they would not choose a placebo trial at all. I would also like to highlight a patient survey distributed during the 2021 CCF annual conference. We surveyed 204 patients and caregivers in attendance to try and gather more information on barriers to clinical trial enrollment. This poster was presented at several conferences. 60% of the patients at the time of the survey were receiving systemic treatment. 57% of those were being treated with chemotherapy and 25% were being treated with targeted therapy. 37% of patients were insured by an employer and 35% by Medicare or Medicare Advantage, and only 1.5% were uninsured. Almost 80% had biomarker testing done, which was mainly ordered by the treating oncologist. Only 27% of the 204 patients had enrolled in a clinical trial, and 71% of those had enrolled in one clinical trial, and 26% of those had enrolled in at least 2 clinical trials. 23% of the patients were told they were not eligible for a clinical trial due to not having a specific biomarker and for non-measurable disease. The findings of the survey suggest that the clinical trial enrollment rate is still low for cholangiocarcinoma patients. Evaluating the eligibility criteria for clinical trials, which is a critical barrier to enrollment, is crucial. And we need to provide clinical trials, not just for actionable mutations, but we need to consider expanded access programs and better designed clinical trials to provide treatment opportunities and hope for more patients. All this was learned, but just by asking the patients. Through the International Cholangiocarcinoma Patient Registry, or ICPR, patients can help power research. Patients become a part of the collaborative effort between patients and the global research community by allowing investigators access to their de-identified health records. The goals for using this data is to build the richest, continually updated database of cholangiocarcinoma natural history data, to have the ability for pharma to utilize this data set in IND filings, and to provide rich publication environment for academia, and use it as a synthetic control arm for the FDA requirements. I want to thank my NCI team. Because of the people on this slide, I have the ability and opportunity to use my voice to represent patients in this community every single day. I feel like I've come full circle. I still get goosebumps when I watch Dr. Rosenberg present the data and show my slide in big research conferences. I've graduated from patient 3737 to patient MB. And Rebecca will probably talk more about C3, but to me, this is the full circle moment. Being asked to be a patient representative on the study team for the same treatment that saved my life, with the same research scientist who stood by my hospital bed so many years ago when I received my first cell treatment. I do feel like I can bring important aspects to this study by living the experience myself, and I encourage all of you who are running trials to involve patients early and often. It will be a win-win situation for all involved. And I would like to end by thanking you and for this opportunity to present. And I invite you all to join us at the Cholangiocarcinoma Foundation Annual Conference in April. Thank you.
Thank you so much, Melinda, for sharing your inspiring story and for all of the inspiring work you've done on behalf of our patients. I think Dr. Mertel is going to introduce our last speaker.
Yes, thank you. Last but not least, Dr. Rebecca Auer, my friend and mentor, I guess, and boss, in fact. She is a surgical oncologist and professor of surgery and the professor in the departments of biochemistry, microbiology, and immunology at the University of Ottawa. She is the scientific director for cancer therapeutics at our research institute, the Ottawa Hospital Research Institute, and a senior scientist. She has done training in surgical oncology at Memorial Sloan Kettering Cancer Center in New York City and practices as a surgical oncologist. She is world-renowned for her research in surgical oncology and primarily translational research and clinical trials, where her work has looked at the impact of surgery on immune system and subsequent cancer recurrence. I'm very excited to have you on the panel today, and I think it'll be very interesting. Thank you.
Thank you so much. I'll just see my slides okay?
Yeah.
Great. So thank you very much for including me on the panel. Really interesting work, and also very inspired by Melinda and have been since I first had the pleasure of meeting her. And thank you, Guillaume, for thinking of me to participate. I'm going to talk a little bit, it's a bit of an unusual talk for me as a surgeon and researcher because it's not really founded in data, but it's a little bit of my experience and what I've kind of come to realize around the importance of research. And I kind of call it the power of yet. So, you know, as we all think about research, the translation from the lab to the clinic and then through to standard of care, we of course think of clinical trials as phase one, when that biomedical discovery leaves the lab and then goes to be evaluated in patients. And we're really looking for safety and maybe a small signal of efficacy. And I call this little part at the end the tail of the curve. And I think increasingly we recognize that this little tail of the curve is like a window into the possibilities of maybe a different outcome than the one that has been presented to you as a patient. And then phase two is kind of trying to find the best patient, the best treatment regimen, the best timing for this treatment so that we can make this tail of the curve much higher and more patients can potentially have hope from this treatment. And then lastly, phase three is kind of defining the new treatment as now the new standard of care and comparing it with the current practice. And I think this is how I often have thought about clinical trials as a clinician. But when I started to look through the eyes more of a patient, I think I see phase 1 clinical trials for, at least for patients, as an opportunity to maybe experience a miracle. I think we got to give patients a lot of credit. They understand that the chance of having an exceptional response is not significantly high, although I would argue increasingly with the amazing immunotherapies and targeted therapies that we have, that this is increasingly possible. But this is maybe like the small chance that I will experience something which I feel would be, you know, a miracle. I've been told that my life expectancy is less than a year and there is no cure. And then phase 2 is kind of unraveling that miracle, like understanding who is going to be most likely to experience that miracle, but it's also access to therapy in some ways, because, you know, this is a therapy that can't be accessed in any other way, and it's the only opportunity potentially that patients have. And then phase 3 is kind of normalizing the miracle. It's also an opportunity to access potentially a new therapy. And again, I think important that what Melinda talked about in terms of crossover, because when it's appropriate, I think that allows patients to access these therapies, whether or not they're randomized to initially to a placebo or standard of care arm. I think it's amazing to me how important hope is in the journey for a cancer patient. And I think I understood this as a clinician. I think I understand it even better now. Even patients at the very end of their life, when they are in palliative care, still hope. And they actually even still hope for cure, even when all evidence would suggest it's not possible. And so hope has been linked to improved resilience, quality of life, reduced anxiety and depression, longevity, and pretty much every disease that has been studied. It is definitely possible to give patients false information, but I don't think you can give a patient false hope. I think we need to meet patients where they are. You give them the information that they need to know about their disease, and then find out where they are with that information and meet them there. And I think the journey is as important as the outcome. And when I say that, I mean that having hope, even if that hope isn't realized at the end of your trial, at the end of the trial that you participate in, even if that targeted therapy hasn't helped, you still lived with hope during that time. And actually that is in and of itself a valuable thing. I always like this quote from Christopher Reeve: once you choose hope, anything is possible. And I tell this story often about my middle son, who came home one day when he was 7 and said to me, "Mom, I know what the most powerful word in the English language is." And I said, "Oh, what is that?" And he said, "It's yet. Because if you add yet to the end of any sentence, you change something from impossible to possible." And ever since that day, I have changed the way I speak to patients. When they will ask me, "Well, Dr. Auer, is this cancer curable?" If it's not curable today, I will tell them it is not curable yet, because yet allows you to potentially live with hope. And so for me, research and the why around research is in part to provide patients with that hope. I think research in medicine, and particularly in oncology, drives that power of yet. So if we start to reimagine the process of discovery translation through the clinical trial paradigm from a patient's perspective, I think we have to keep the power of yet and hope in mind. It's important to remember that cancer research comes partly from where we've been with cancer therapy. And when you think about where we've been with cancer therapy, you think about surgery, radiation, chemotherapy. These are the mainstay platforms, and they've had a huge impact on cancer outcomes. There's no question. But they come with a fair share of toxicity, and that toxicity is, of course, borne by the patient. Think about chemotherapy. The widely considered father of chemotherapy is Dusty Rhodes, pictured here on Time magazine. But he actually came from the military, where he was the chief of the medical weapons division. So really, that whole concept of chemotherapy comes from military warfare. These are poisons, and they're poisons that are designed to kill the cancer and hopefully not kill the patient. So again, this is where our history has been, and this is where patients have been. and still are in some cases, with the side effects of these therapies that, yes, in some cases have been effective, but have a lot of strain on the patient. And then where have we been with clinical trials? Well, for a very long time, for just about as long, we've had clinical trials that progress through these 3 phases that we just talked about. So we don't know, this group of patients is all very similar. We don't know what will work for them. We start with safety, then we try and figure out who is best to respond or when, and then we do a 1,000 patient clinical trial to try and find out if the answer is that it's better. And these clinical trials are still important in some cases, but I think we need to think about where we are now. And this is really based on an incredible 5-decade explosion of research in cell biology, molecular therapy, and immunotherapy. Consider that it took 13 years to sequence the first human genome in 2003. And it costs about $2.7 billion. And now you can sequence a human genome in 1 to 2 days, and it costs about $1,000. And things are moving really fast. You know, CRISPR-Cas9 gene editing was just discovered in 2012, and now, just over a decade later, it's an FDA-approved treatment for, in this case, sickle cell anemia. Things are moving very fast. Immunotherapy, the same thing. Immune checkpoint blockade was first approved in 2011. And now it's being used in so many different cancers and different combinations. That really has transformed our understanding of how the immune system affects cancer. We have now cellular immunotherapies, and although the first one was only approved in 2010, there's now 26 more therapies approved, and 7 of these in 2023. So again, the pace of discovery is quite significant. And again, in 2017, the first ever tissue agnostic, so it doesn't matter where the tumor's from, if it's MSI high, there's a therapy for it. So these are really transformational things. So the science and then the therapeutic pipeline has really, really changed. That's just a little picture of a T cell killing a cancer cell. And so this is today, but where we're going is potentially, understanding so much more about the cancers, combinations of mutations, combinations of therapies. So maybe we have, 5 dozen different therapies today that are targeted or uniquely available to certain subtypes of patients, but this is what it would look like tomorrow. And we see this with FDA approvals that are mostly in molecularly targeted drugs and immunotherapies. The pace of approvals is exponential. So how has clinical trial design changed in that same period of time? Essentially not at all. We really do the same thing, even though this design, I would argue, no longer fits with the biomedical science and the pipeline that we have developed. And when you think about new clinical trials now that are very specifically targeting molecular subtypes, even in immunotherapy, HLA subtypes for certain cell-based therapies, and we still have this paradigm that ultimately leads patients with limited access to clinical trials. I just wanted to share Adam's story, and this is an example of how clinical trials and access to experimental therapies can really transform patient care. So Adam is the father of 3 boys. He had been recently appointed to the CEO in Canada and was diagnosed with stage 4 cholangiocarcinoma in May 2022. He was 49 at the time. He started standard treatment with chemotherapy. Immunotherapy had yet to be approved. And his life expectancy was 7 to 11 months. And this was devastating. I know that because Adam is my husband and he's the father of my 3 children. Fortunately, very early on, probably within like 48 hours of his diagnosis, I bumped into my mentor and research colleague, Dr. John Bell, and he kind of reminded me how much hope there is in the research space. And he said, don't have to overthink this. You don't have to cure everyone with cancer. You just have to figure it out for one person, and maybe we cure a few more in the process. So let's see what we can do. And it was really that moment. Nothing had changed. We were still planning to start chemotherapy in a couple of days, but it was how I felt and how I was able to move forward with hope that really changed things. And that's what I mean when I say the journey is as important as the outcome. For me, that moment was really transformational, and I realized there was maybe hope that I hadn't thought about before. Adam's story is different from most patients with cholangiocarcinoma in Canada. We paid for molecular testing out of pocket, which isn't available in Canada. He had a few different mutations, including FGF2 and also a BRCA mutation. We were able to get immunotherapy because the trial had just been presented. So we were able to get that through compassionate access, and subsequently found out that BRCA patients are enriched in this tail, the tail of hope. Because he was a BRCA mutated cancer, we were also able to access targeted treatment through olaparib, again through self-pay, which most patients would not be able to access. And finally, we went actually emailed Melinda probably a couple of days after Adam's diagnosis, and she emailed me right back, and we ended up going down to the NIH and were enrolled in a clinical trial with Steve Rosenberg as well. So a lot of hope in the opportunity to participate in research. It's been almost 2 years now. Adam is back to working full time, being a father to our children, feeling well. No more chemotherapy. He's just on the PARP inhibitor and really doing well. And so for me, this was a really important message because, for example, the clinical trial of Lynparza, the only clinical trial that was available for him to participate was in Hong Kong. And so it would be basically impossible for us to do that. But fortunately, Lynparza or olaparib is an approved product for ovarian and breast and prostate and pancreas, so we're able to purchase it. But I can only imagine how frustrating it is for patients who can't do that either because it's not available, who would like to participate in the clinical trial, but there's none available. This is a Canadian situation, which I think is a little bit different in the US, but it might be true for many Americans who don't have insurance. We don't have access to molecular testing, so if you can't afford it, you can't get it. Even if you can get it, and you do have a targeted agent, or you would respond to immunotherapy, but it's not standard of care, you'd have to find either a site-specific clinical trial, which in the case of something like cholangiocarcinoma is very uncommon, a site-agnostic clinical trial, which there really aren't enough of, maybe getting it on compassionate access, paying for it off-label, or what's more likely to happen is you don't have any access. So I think we really need to figure out what the barriers are, because companies want to do clinical trials, investigators want to do clinical trials, but there are a lot of reasons why this system is not working. I think it's really important that we start recognizing that while participation in research isn't necessarily standard of care, providing patients with an opportunity to participate in research should be considered standard of care. So patients can really enhance clinical trial design, as Melinda already talked about. And I think partly as we already went through with the first talk today, defining questions that actually matter to them. What is important to patients? Helping to design trials that are more feasible and more acceptable with outcomes that matter to them. Advocating for flexible, decentralized, or delegated trials for closer to home. And I think this is really important. Patients have a voice to sort of tell regulatory agencies in Canada, it's Health Canada, in the US, it's FDA, that they need to have a different view of oversight around clinical trials so that these rare types of cancers with rare molecular mutations, that these trials can be done and there's no geographic disparity in access in these trials. I think patients can really help advocating for clinical trial access and funding, and even for drug coverage post-trial completion. And patients have an opportunity, again, Melinda talked about the cholangiocarcinoma, International Cholangiocarcinoma Registry, but where they actually can have control of their own data and provide that data for real world evidence. And I think that institutions, organizations, governments are so worried about privacy. It's creating all these insane barriers to accessing data. But if we give patients the data and we give them the opportunity to share that data, a lot of those things go away. So as Melinda mentioned, we were able to start the Canadian Cholangiocarcinoma Collaborative, and really our focus was to provide patients with hope, hope through access to personalized testing, expert opinions, treatments, but importantly through clinical trials and access to research. And we did manage to get a $7.4 million grant to start doing this. And really, for me, this has been one of the most powerful experiences I've participated in as a researcher, because advocating alongside patients and working hand in hand with patients to develop clinical trials, to understand what matters for them in terms of preclinical pipeline research has been really incredible for me. This is the aim that I run, where we essentially have what's called a clinical trial navigator. So if a patient is diagnosed and maybe they're in a center where their local oncologist hasn't treated very many patients with cholangiocarcinoma, that they can contact our research navigator, and they sign up for C3, gives them an opportunity to have molecular testing, which we pay for. Currently, Canadian patients can't participate in the registry unless they have their own records, but we're through our processes, we're getting Canadian patients into the registry to voluntarily share their data. We have access to national multidisciplinary rounds, participation in HOPE study, clinical trial matching, as well as some other initiatives, including starting a clinical trial of the same therapy that Adam and Melinda had down in the US, to have access to that therapy in Canada. So that's the end of my presentation. I wanted to say thank you to everyone for listening, and for all the C3 members who've put so much effort into creating the C3.
Thank you so much, Dr. Auer. Very, very powerful presentation, as always. I think we have a little bit of time left for questions. I think it would be great. So anybody in the audience who wishes to ask a question, now is a good moment. I think we've heard about the nuts and bolts of patient-reported outcomes, all the way to patient input and caregiver input. So I'm happy to start with a question. This can be for any panelist, but I always find it very difficult, and I think Dr. Krause alluded to this. I always find it very difficult to interpret patient-reported outcomes when we read them in manuscripts and such. And I don't know if there's a better way to present that information. I guess this is always what comes to mind when I read these things, and I find that perhaps a lot of the nuance is lost in the wealth of information that is presented when we see these types of papers. And I don't know if the panelists can comment, but I think interpretability and presentation is a little bit of a challenge in my mind.
Yeah, it's not quite, survival, which is pretty cut and dry. And when you're dealing with things on Likert scales and trying to put yourself in someone else's position, it's not the easiest. I understand. That's why it's really important. So one of the things that Jeff Sloan has said a long time is what's believable. What endpoints when you are more sort of understandable and what audience really is important. So when you see in the an article where they're talking about nausea and vomiting or NG tubes, you get that. You see it and you say, okay, that my patients, that affects my patients. When you see patient activation, not as much, because it's not really what it may not be. It's not really your world as much, and that's why sort of sometimes I get it. But of course, patient activation in the survivorship world, where somebody self-care is so darn important, that it is a primary output. So you're right, and some things are sort of more made, and that's why you see them in Lancet GI that you're going to read, and you'll get that, but you're less likely maybe to see some. Anyways, it's just an opinion, but it's an imperfect world, and so but that's one. Anyways, one.
Thank
thought.
you. Shashir, question.
Yeah, absolutely. Thank you all. I actually have a comment and then two questions. my comments maybe to two people. So Dr. Auer, thank you again very much for your story and sharing your story. But more importantly, I think what you're doing in Canada and the effort you are doing to really get it all done there and get the availability to patients there is just phenomenal. And I'm super excited that now we're opening up the database registry that we have here in the US to the Canadian population. I think it's just going to help unify it, grow it, and really bring it together. And you know, I think it's just as awesome. Melinda, you're an angel on earth, as I've told you many, many times, and cherish our friendship for the past 8 years. So I can't say enough about you. My two questions, one to Dr. Kraus and one to Dr. Ikoma. Regarding the PROs, Dr. Kraus, I think you're working it at the NCTN level has been phenomenal. And it's amazing that you've done these trials with PROs as primary outcomes, particularly in your malignant bowel obstruction study. My experience in the NCTN is mostly all the PROs have been secondary outcomes, and I've encountered problems with funding. As we meet with the PRO team and we come up with this whole plan and we have all these questions ready to go, and then it comes down to, well, who's going to fund this? And it doesn't seem like so I'm predominantly in the ECOG-ACRIN system, and it doesn't seem like the NCI, the NCTN, CTEP, ECOG-ACRIN kind of reliably provide funding. So if you could provide a comments a little bit about funding PROs at the NCTN level. And then to Dr. Ikoma, in terms of the duration of PROs and trials, or you're designing an instrument for clinical practice for longevity and to do it real time. But let's say in a clinical trial perspective, if it's a technical trial, how long do you think, all the MIS studies have shown that the benefit in the PRO standpoint is gone by like 90 days, definitely by 6 months, the benefit's gone. So how long do we need to continue to test PROs for technical trials and or for therapeutic trials? How long do you think it's valuable to keep going, again, balancing the funding issue? Thanks again to everyone.
So it's a great question as far as sort of the funding, and the committee that I lead at SWOG, when you're dealing with palliative care or survivorship, there's very few drug trials. Thankfully, Dr. Cham has one, and it's going to be starting. We should definitely talk about that. But you often need to get funding to get a study open in that particular NCTN group, or committee, so how to do that is basically, first of all, you look at program announcements, what fits there are. The original grant that started all this was an RFA. There are RFAs that fit, that will get it. And then it also goes to what's the correct review group. Even you can recommend which review group, because there are review groups that get it and are a lot more likely to at least consider a PRO endpoint. Now, it doesn't mean that, like you saw with the S1360, which is funded by AHRQ, we sought a more objective primary outcome, knowing believability, etc. And yet it's incredibly important to do the secondary quality of life endpoints. And so it depends also, the science of it is always really the most important. How well tested is it in this population? What's your pilot data, et cetera, to make it really believable that they're willing to fund it.
So before Dr. Ikoma goes, I mean, to follow up on that, do you feel like to do really quality PRO work, you do need extramural funding for an NCTN study? Like you have HRQ or you have other like RFPs. I mean, have you had experience where the NCTN has actually funded it?
It's a really important question, and because you're limited by what your statisticians can or are willing to do, and so the extramural funding that I sought, like for HRQ, was really for statistician sort of effort that's sort of a little bit beyond them. The groups, ECOG, Alliance, all they're funded to accrue patients, to analyze patients. Most of the money goes to the statisticians, of course, and the accrual costs they take on. So you shouldn't really need it for every study. But I will tell you also, one of the biggest problems for those of you who write studies and is going to the steering committee one of the experts in the world is Dr. Sham. You go to the steering committee, you're taking your life in your hands. But if you come in there with a grant, you're vetted, you don't need to go to the steering committee. Your study happened. And so it's another reason why if you have a fundable sort of study, it does sort of smooth out that process. S1316 never would have been approved by the steering committee, but we were funded by a federal institution, and it sailed. And so at least through that, you know what I mean? And so there are risks. It all depends on the idea. I'm always happy to talk to people about ideas, and it depends on the idea and sort of how to get it done. Yeah.
Got it. Thank you.
Dr. Sham?
Well, I think Dr. Como, do you want to go just
Oh, sorry.
answer Michael's question? Then I just one last question to wrap up afterwards.
Of course, yeah. Thanks for the question about the duration of the PRO collection. And that's a good point, but that probably depends on each study and what you want to trying to achieve. Like you said, the collection of the PRO, particularly when we are trying to achieve the high rate of the response, it's very labor intense and then very costly, you know, to create and as the upper GI surgery, probably we're budgeting almost close to the $100,000 to make one, because not only the study coordinator, I'm hiring 2 postdoc, and including myself, we are going to the patient's room day 3, day 7 after surgery to ask them to report that. And then, but we're that study duration is 1 month for each patient. You know, we get those intense, you know, collection, trying to get the 100%, you know, collection rate, but to get it done at the 1 month after the surgery. And then we combine esophagus, gastric, and a pancreas cancer patient all together, because get this done as soon as possible. We are trying to achieve this within 1 year. You know, it's if we try to do that for only for gastric cancer, for example, it's gonna take maybe 3 years. And then I think the point is, you know, it is very costly study, have to get it done as soon as possible. And then, like you said, particularly for my, you know, interest for to show the proof of the MIS benefit, and then like you said, it's the benefit of the quality of life, probably at longest it's probably 2 or 3 months, as you said. And then, but at the same time, we really don't have much data about how those patients' quality of life dynamically changed during that time period. And also, you know, we often see the patient before the surgery, they ask us, hey, what is the recovery time? And we really don't have a good answer for that. You know, what I typically say is my goal is to let you feel back to normal, you know, 80% back to normal within 2 months, something like that. But we really don't have a, you know, quite number for that. And that is what I really want to achieve by doing this study, and then for those description. And the eventual goal is to incorporate this into more regular practice. You know, it doesn't need to be study, you know, to collect the patient reported outcomes. So I'm in a committee for the incorporation into the EPIC. So once we develop this, we will aim to get it done as the normal practice. And then I'm pretty sure it's going to be the direction for the CMS and a payer requirement to get those, you know, patient reported outcome collection. So wants to take a lead on that.
Thank you.
Thanks so much, Dr. Como. I just had one last question for the panel as we wrap up this evening, and it's potentially a little bit provocative. And maybe you know, Melinda, it's more for you, but anyone can certainly answer. And that has to do with patient compensation for PROs and trial participation. When Robert and I were going through the steering committee, they asked us, we have PROs as a secondary outcome for S2408. And the steering committee asked us, how are you going to compensate your participants for PRO participation? And I was kind of taken aback and said, well, I don't know, like, do we do that? Is that a thing? And so the question is, should we compensate patients? And if so, is there any way to do that outside monetary remuneration? And do you know any examples of that?
Yes,
Sure.
good
I mean,
question.
we do in
Sorry.
our studies. So basically we give gift cards sometimes to markets or other things. And so you know, the cooperative group networks, the NCTN, is a little more difficult to swing that one for various political reasons. But if I was writing a grant, which I do, I put in And you obviously, when you have to put it in, you put in a reimbursement that's reasonable, that the IRBs, et cetera, agree is reasonable, but not sort of going to bias how somebody responds to a survey. So you put in $50 every time they finish or $50 worth of something every time they complete a set of surveys, or that's sort of a reasonable thing to do. In the cooperative group system, it's just more difficult, and people are so excited to participate. Often you're hopeful anyway that they're still willing to fill out the surveys or participate in the surveys without necessarily that remuneration.
I agree. I think it depends on the situation, but I also think patients' time and energy and effort is valuable, and they're a partner with you in on this research, and sometimes I think compensation is necessary, and I think it's okay. So just depending on the situation, we try to always encourage that every time we're telling, if industry wants patient advisory boards, we make sure we have honorariums written in, to their participation for their time. To me, it's valuable feedback and it's worth the compensation.
Let me give us some objection. I'm sorry if it offended something, but I hope collection of patient-reported outcome is not that bothersome worth the paying the money to patient, and I would rather want patient to consider that is opportunity for them to more like a subjectively communicate their symptoms with us. So what I typically do is give the iPad, the nurses give the iPad before the patient, see me at the clinic. It's 3-minute survey. And then when I get into the room, I can review the symptom with the patient. It actually helps a lot to shorten the time for the consultation to the patient. Often, there's very often patient, I'm doing great, I'm doing fine. And then, when I review the symptom, hey, you have the constipation at the scale of 7. Probably you didn't tell me about this kind of thing. I think patient-reported outcome is a great tool to improve the communication between us. And then I hope, again, hope it doesn't need the payment to the patient.
Well, let me just
Good
say
for
that
you. Good for you.
Yeah.
Using the patient-reported outcome is really important as you're doing, but as a research tool, I'm
Right.
not quite sure I agree that you can do it that way, because you're going to bias your findings. And so it's just something, and so that's why in a research setting, if you can write into it to give remuneration, it's worth it.
Okay, well, we're a little bit over time, but I think it was well worth it. So I would like to thank everyone for attending, participating. Our speakers were amazing. I will show one more time our QR code, which I've been asked to share with the group. So anyone who hasn't filled this survey, we're asking you to participate, please. It would help us tremendously. But otherwise, I will thank everyone for attending and wish you a very pleasant evening. Thank you so much to all the panelists.
Thanks, everyone.
Thank you, everyone.
Oh.
Thank you.